Good afternoon, everyone. I'm Dr. Atul Mishra, and on behalf of Signutra, I welcome all of you to the advanced webinar series where we bring relevant and practical case discussions to enhance pediatricians' understanding of the vital role of specialized nutrition in a child's recovery. Pneumonia per se is a major cause of child mortality among children under 5 years worldwide. Most of the deaths occur from severe pneumonia, and the management of severe childhood pneumonia requires early identification, proper management in the landscape of pharmaceutical, conservative, supportive, and nutrition care, and prompt referral in conditions of child respiratory distress, and also the availability of intensive quality of care. In today's episode, we will be discussing about the nutrition practices and outcomes in pediatric respiratory illnesses. And to highlight the same, we are joined by eminent speakers and experts in the field of community pediatrics, pediatric critical care, and clinical nutrition. Please welcome our keynote speakers for today. We have with us Dr. Namit Jerath. He's a senior consultant pediatric pulmonology and critical care in the Breast Apollo Hospital, New Delhi. Welcome, sir. Second, we have Dr. A.G. Karthikeyan, a senior consultant pediatrician and neonatologist from Chennai. Welcome to you, sir, as well. And Ms. Anita Jatana, chief dietitian, Indraprasth Apollo Hospital, New Delhi. Welcome, ma'am. It's a great honor and privilege to host you along with Dr. Namit as well as Dr. A.G. Karthikeyan. Today, our first speaker, Dr. A.G. Karthikeyan, will be showcasing a clinical presentation of a case of community-acquired pneumonia. Followed by that, we'll have a scenario two where Dr. Namit Jirath will be taking us through an overview of PICU management of acute respiratory distress syndrome, ARDS. And the last session which we'll be having today would be from Ms. Anita Jatana. She will be highlighting the dietitian's perspective on the role of nutrition in pediatric respiratory illnesses. If you have any questions meanwhile during the sessions, please text them in the question box. We'll be taking as many relevant questions as possible in the dedicated Q&A session after the three sessions. Now, without further delay, let me invite Dr. A.G. Karthikeyan to present a case of community-acquired pneumonia, and a good nutrition support may help the child to optimize the recovery. Over to you, sir.
Thank you, Dr. Atul, and thank you, the entire team of Signutra, for this wonderful opportunity to be along with stalwarts in pediatric practice. And meantime, I'll take this opportunity to welcome Dr. Namit and dietitian Ms. Anita Jatana. And without much ado, Dr. Atul had introduced about pneumonia. So I'll go to pneumonia, pediatrician's perspective on approach to pneumonia in a community setting. So is everything good in the audio visuals?
Yeah, great.
Yeah.
Good to go.
So we'll start with a case scenario. Since it is like I had prepared this presentation for a dialogue-oriented session, but since it is more of a, since we speakers have a separate link and the audience have a separate link, you won't be able to interact immediately. So I'll be throwing the questions and I'll start answering them, so that at the end of the session, during the Q&A sessions, we'll have a healthy discussion. And this is a 3-year-old boy, Raghu, who was referred by a general practitioner. He was seen by him 4 days ago with cough and fever and diagnosed with a viral upper respiratory tract infection. So this is a common scenario. The following day, he had returned with unrelenting fever and worsening cough. So immediately, the general practitioner had started him on oral antibiotics. Now, he was complaining of abdominal pain and had vomited once. Now the general practitioner got worried, so that he thought, is he going to get dehydrated? Is he going to have, or is he having any urinary tract infection or any intra-abdominal pathology? He has not been immunized up to date, but there is no other medical history of note, and he is referred here. On examination, his height is 25th centile, weight is 3rd centile, he is miserable, flushed, toxic, and the temperature is 102 degrees Fahrenheit with a capillary refill of approximately 2 seconds. His pulse is 140 beats per minute, saturation 91% in room air, and blood pressure 85/60. He seems to be in pain, especially when he coughs, and his respiratory rate is around 50 with nasal flaring. There is a dullness to percussion in the right lower zone posteriorly, with decreased breath sounds, and occasional bronchial breathing is also present. But he seems to be reluctant to have his abdomen examined, but the bowel sounds are normal. So this is a common or casual scenario that we see day in and day out in our OP practice as well as hospital-based practice. So his investigation revealed a hemoglobin of 9.8. White cells counts were way high with a neutrophil predominance, and CRP was sky high. So this is his X-ray. So what will be your comment? What will be your working diagnosis at this point of time? Before that, what is this finding that you see in this X-ray? So as you could see, the chest X-ray shows a loss of right hemidiaphragm, right lower zone consolidation, normal right heart border, which is a characteristic feature of right lower lobe pneumonia. So lower lobe pneumonia should always be on the list of differential diagnosis for abdominal pain in children. And young children rarely localize pain, but observation should establish whether they have pleuritic pain also. They may have a shallow breathing or may just simply sit very still, hardly moving the affected side. Is there any risk factors that Raghav have? Just going back to the history, are there any risk factors that he has? Yes, one major risk factor is he is undernourished. His weight is third centile, he's anemic. Another one is he is unimmunized. These are the major risk factors that Raghav is having. So, as a clinician, respiratory system is the major, as a pediatrician, is a major system or the major disease that we encounter day in and day out. What is the percentage of community-acquired pneumonia that we see in our practice? And out of the cases, how many progress to severe pneumonia and how many would require hospitalization? And in which age group this is most common? So these three questions will be answered in the next few slides. So basically, I have chosen this scenario before COVID 2019 because not to overlap COVID with pneumonia. So in 2019, as you could see, it killed around 7.5 lakh children under the age of 5 years, accounting for 14% of all the deaths of children under 5 years old, and 22% of all the deaths in children between 1 to 5 years of age. Younger children under the age of 2 in developing world account for nearly 80% of pediatric deaths secondary to pneumonia. And it's almost 150 million new episodes are reported every year worldwide, 95% from developing countries. And India is contributing tremendously to this, almost 40 to 50 billion episodes of pneumonia. So there has been a paradigm shift in the incidence and case fatality rate of pneumonia. As you would rightly agree, after 2018, when pneumococcal conjugate vaccine was introduced into our universal immunization program, the expected outcome is a marked decline in the incidence of pneumonia. Since Dr. Amit is also here, he'll definitely agree that maybe the OP load of pneumonia or the mild pneumonias would have reduced, but invasive pneumococcal disease and severe pneumonia requiring hospitalization is still the same, or I can say a little bit higher, probably because the pneumococcal conjugate vaccine that we have introduced has certain limitation. It has certain serotypes that is being covered. But the moment we cover or we try to control certain tier serotypes, newer emerging serotypes do happen, and that could be the reason for this invasive pneumococcal disease. So in way back in 2000, this was the incidence of pneumonia under 5 years of age, 657 per 1,000, and it has dropped to 403, but the case fatality rate has increased almost 8-fold. So what are the risk factors that we generally observe in our practice? And what are the pathogens that are predominant? And etiology-wise, are there any differences in the pathogens that affect the children? So as you all know, the lack of breastfeeding, it starts with nutrition. Nutrition is the backbone of immunity. Nutrition is the backbone of prevention of all these diseases. So lack of exclusive breastfeeding, low birth weight, undernutrition, indoor air pollution, overcrowding, lack of immunization, especially measles, exposure to cigarette smoke, and incomplete or inadequate vaccination. These are the major risk factors. Underlying medical conditions or any cardiopulmonary disorders like congenital heart disease, bronchopulmonary dysplasias, cystic fibrosis, asthma, neuromuscular disorders, especially those associated with depressed consciousness, and GI disorders like reflux, gastroesophageal reflux, and TEF, tracheoesophageal fistulars. These are also major risk factors. So microbiology, it's almost 30% by pneumococcus, and 10 to 15% are caused by H. influenzae and RSV each. Other important causes include Staph aureus, gram-negative organism, mycoplasma, and chlamydia. So this is a prospective cohort study among 2,345 Indian children. Nasopharyngeal aspirate showed a predominance of streptococci followed by H. influenzae and Staph. Blood was dominated by Staph aureus, followed by strep pneumonia and Klebsiella pneumonia. Whereas the atypical things like mycoplasma and chlamydia serology were positive in 4 and 1% respectively. And age-wise also the etiology differs. As you all will agree, it's a gram-negative predominance in neonates and early infancy. 0 to 2 months, the common is E. coli, Klebsiella pneumonia, Staph. Whereas 2 months to 5 years, it is predominantly by streptococcal pneumonia, H. influenzae, Staph. Over 5 years, strep pneumonia, and comes the atypical organism. Less common are H. influenzae and Staph. So basically, how do they present? How do you differentiate the features with varying etiology? Generally, the presentation varies age-wise. The symptoms and signs varies age-wise. A newborn never comes with a severe cough, but poor feeding, irritability, retractions, and hypoxemia may be the presenting features. In infants, cough, poor feeding, tachypnea, retractions, hypoxemia, may have low-grade fever or no fever at all. Older children may present with fever, cough, tachypnea, lethargy, dehydration, and chest pain. An adolescent can just present with headache, abdominal pain, and chest pain. So fever, cyanosis, respiratory distress is a sensitive sign. Neonates, young infants, and young children may present only with fever and leukocytosis. Tachypnea is more sensitive and specific than crackles. And according to WHO, it is often used to diagnose in the lower middle income countries where the lower chest indrawing is the main clinical sign. And there is wheezing, it is mostly viral. It could be mycoplasma or chlamydia, unlikely of bacterial pneumonia. Auscultative findings are generally not sensitive. So this is the revised WHO guidelines on clinical diagnosis. Just cough and cold, it is no pneumonia. And the respiratory rate, fast breathing. For children between 2 months to 1 year, more than 50, 1 to 5 years, more than 40, and more than 5 years, more than 30. This is the respiratory rate. That could be the diagnosing feature for pneumonia and or chest indrawing. We call it a severe pneumonia when the child is not able to drink or feed. There is persistent vomiting, cyanosis or convulsions, lethargy, stridor in a calm child, and severe malnutrition. The best way is respiratory rate. Over 60 seconds we have to assess a child, not just 10 seconds and multiply it by 6. So just by looking into the clinical features, we can come to a diagnosis of the etiology. Is it a viral, streptococcal, staph, or atypical? So generally viral, it is, there will be a prodrome of a short upper respiratory tract infection. It will be a gradual onset. Less toxic child, wheeze may be associated. Usually it's bilateral and lasts for 3 to 5 days and resolves. If it is strep pneumonia, it's more toxic child, rapid progression, lobar in nature, gastrointestinal manifestation may be present. If there are empyema, cellulitis, necrotizing pneumonia or pneumococcal, think of staph. Atypical, again, it is a diffuse lung involvement, may not be a sick child. Wheezing might be present, more like a viral pneumonia. There is a resurgence of pertussis, upper respiratory prodrome, followed by paroxysmal cough, gasping, stridor with color change. The cough may be persistent for months. Have it in mind because there is a resurgence of pertussis. Always have it in mind when there is chronic cough, think of Mycobacterium tuberculosis also. So do you recommend routine chest x-rays or CT in a child presenting with these symptoms? We'll not talk about a tertiary care center or a metropolitan city, since it is a community-acquired pneumonia, and this is actually projected, this webinar is projected, I heard almost 2,000, more than 1,000 pediatricians. We'll think about the tier 2 cities, towns, and villages also. What are the other laboratory investigations that you consider, and when do you recommend them? Basically, routine chest x-ray, if you're in a resource crunch situation, is not necessary for mild, uncomplicated lower respiratory tract infection who are well enough to be treated as outpatients. High resolution CT is generally not necessary. X-ray is generally warranted when the findings are inconclusive and due to have some disparity to rule out possible other causes of respiratory distress, infants with fever without focus and leukocytosis, and hospitalized community-acquired pneumonia to assess the opacity and suspected with complications like effusions or empyema. Generally, younger the child, you all know it's AP view, older the child, it's PA view that you give. Negative X-ray generally excludes pneumonia in most of the children more than 3 months. Lateral views are definitely necessary in a child who's been hospitalized with community-acquired pneumonia. So these are the various mnemonic patterns X-ray. I don't want to go into the details of this because the crux of today's discussion will be more on nutritional aspect. I thought we'll introduce more of clinical and nutrition also, because at the end of this session, you'll be understanding that when you merge both these treatments, that is the proper treatment per se, along with nutritional intervention, it will be having the best outcome. So no other investigations are required in OPD. In hospitalized children, CBC, blood culture, chest X-ray, CRP, procalcitonin, RT-PCR, and BioFire definitely has come as a real good kitty in our armamentarium. And combination of procalcitonin, CRP, and CBC better to understand the treatment response. ELISA for mycoplasma. Pulse oximetry is definitely helpful in finding out the response in the hospitalized children. So now we have done the investigation. So we should understand what are all the differentials that should run in our mind when you see a child with acquired pneumonia, community-acquired pneumonia, and what are the complications and how often do we observe them? So basically, infectious causes, bronchiolitis, younger the baby, bronchiolitis may be there. You have to rule out depending upon the clinical scenario. Upper respiratory tract infection, otitis media. Non-infectious causes is like inhalational pneumonia, child with having chronic gastroesophageal reflux, foreign body aspiration, intoxication, any congenital disorders, anatomical abnormalities like CLE, CCAM, neoplasms, metastasis, and pulmonary embolism. Extrapulmonary causes like sepsis, cardiac anomalies, endocrinopathies, neuromuscular disorders, IEM, and GI emergencies also have to be in our differential diagnosis. The basic complications are pleural effusions and empyema, necrotizing pneumonia, lung abscess, pneumotocele, and hyponatremia. So you all know effusions are more commonly associated with H influenza, staph, empyema, abscess, and pneumotoceles. Mycoplasma may have extrapulmonary complications like arthritis, meningitis, whereas local and hematogenous spread of tuberculosis can result in a mild manifestation both inside and outside the lung. Systemic complications include dehydration, sepsis, and HUS. So I'll just rush through the clinical management of the community-acquired pneumonia in OPD and what are the supportive treatment that is necessary. We all know less than 3 months, never as outpatient, always admit the child and treat in a resource plenty place. Resource limited place we'll discuss. 3 months to 5 years, still amoxicillin holds the fort. And still Indian children are susceptible. This pneumococci that the Indian children get is susceptible to 40 to 50 milligram per kilogram per day of pneumonia rather than the higher dose of amoxicillin. And the second line drug will be either co-amoxiclav, cefodoxim, or cefuroxime. If staph is suspected, co-amoxiclav or cefuroxime or linezolide can be used. So macrolides, this is again an important situation because the macrolides are frequently being used in a practice. If a child is immunized against H influenza and pneumococci and it is not responding to the first line of antibiotics, think of using macrolides. Persistence of low-grade fever, cough, and chest X-ray showing some bilateral perihilar streaky infiltrates, think of macrolides. And if you're ruling out staph aureus and the child is having extrapulmonary manifestation and no response to anti-staphylococcal antibiotics, go for macrolides. Never use antibiotics when you're sure that the child is having either bronchiolitis, wheeze-associated lower respiratory tract infection, or asthma. And the major thing is the supportive care and follow-up. Manage the fever and pain, avoid antitussives, maintain hydration, gentle suction of the nares, and identification of deterioration when the caregiver has to come back. Follow-up radiology is generally not necessary unless they fail to resolve. So when do you consider admitting and what are the treatments in hospital that you do? So you all know clinically severe pneumonia is a sick child with tachypnea, cyanosis, altered level of consciousness, hypoxemia. These are the time where you hospitalize a child. Less than 3 months, don't take a chance, hospitalize a child. And always assess the child, assess for the severity, manage, keep reassessing. This is very important in treatment of pneumonia. And we all know less than 3 months, ceftriaxone is generally the antibiotic started now. Other things that can be used are cefodoxime with gentamicin or amikacin. The second generation or second line will be piperacillin tazobactam with or without genta or amikacin, as cefoperazone sulbactam plus or minus genta or amikacin. If staph is suspected, ceftriaxone plus cloxacillin or vancomycin. 3 months to 5 years, ampicillin still will be. So supportive care, this I've already done. We'll go to the discharge criteria. Improvement of vital signs, ability to maintain adequate fluid and nutrition orally, ability to maintain oxygen saturation more than 90% in room air, improvement in respiratory status, and overall clinical improvement, including the level of activity, appetite, and decreased fever for at least 12 to 14 years. Stable baseline mental status. Caregiver's ability to administer and child's ability to comply with taking the home antibiotic. So we'll come to the end of my presentation by a few slides on the nutritional aspect and prevention. This is the WHO position paper, which was published in November 2022. Preventing pneumonia in children is an essential component of a strategy to reduce child mortality. Immunization is the most effective way to prevent pneumonia, especially against H influenza, pneumococcus, measles, and pertussis. Adequate nutrition is the second key to improving the child's natural defenses, starting with exclusive breastfeeding for the first 6 months of life. In addition to being effective in preventing pneumonia, it also helps to reduce the length of the illness if the child does become ill. Addressing the environmental factors like air pollution and encouraging good hygiene in crowded homes also reduce the number of children who fall ill with pneumonia. And in children infected with HIV, the antibiotic cotrimoxazole is given daily. WHO and UNICEF integrated this GAPPD, that is Global Action Plan for Pneumonia and Diarrhea, to protect, prevent. Those two we have already seen. To treat pneumonia, focusing on making sure that every sick child has the access to right kind of care either from a community-based health worker or a health facility if the disease is severe, and can get the antibiotics and oxygen they need to get well. So we'll just close the session with few evidences. For children under the age of 5, undernutrition is the single largest risk factors for death and disability, affecting 1 in 4 children worldwide. Stunting, severe wasting, and IUGR are directly responsible to an estimated 2 million deaths every year. And given the interaction between undernutrition, immunodeficiency, and infectious disease, insufficient food intake is directly or indirectly responsible for 35% of all the deaths. And if you could see the geography of hunger, the South Central Asia and Sub-Saharan Africa, 4 out of 5 children suffering from malnutrition live in these just 20 countries. So we are the major geography of hunger. So we have to be dealing this. Long-term effect of this malnutrition leads to a shorter adult height, fewer years of schooling, and lower adult income. They are all linked to malnutrition during early life. As you could see, the GDP of a country could come down because of malnutrition. So what happens? According to Lancet, poor nutrition during the first 2 years of life can have a devastating consequences on his or her physical and cognitive development. And this is the golden interval for nutritional intervention. So how do we actually overcome this? Micronutrient fortification, especially supplementing the food with iodine, iron, vitamin A, zinc, or calcium. And studies have shown that iodization of food substances like water, as with fortification of foods with vitamin A and iron, have a positive effect on micronutrient status and infant mortality. This study, which looked into an age-structured differential equation model of transmission dynamics of pneumonia with treatment and nutritional intervention. I told you, a combination model of treatment and nutritional intervention. So the red line shows without intervention, the number of children improving over a period of time. The yellow line with treatment only, green with nutrition, and when you combine, the blue line. So similarly, it happens with the transmission. So the results, according to the results of this study, the combination of proper nutrition and treatment is the most effective way to reduce pneumonia transmission in children. The study investigators also found that when both were applied to child population, the pneumonia transmission in the community decreased quicker than either intervention alone. And according to the results of this mathematical model, the study authors concluded that proper nutrition can help control the transmission of pneumonia in children. Now we'll touch upon this oral nutrition supplement. This is an Indian study which was published in Journal of International Medical Research in 2018, where they looked into the effect of ONS on growth and recurrent upper respiratory tract infection in picky eating children at nutritional risk. It was a randomized controlled trial. They evaluated the oral nutrition supplement plus dietary counseling versus dietary counseling alone on growth and upper respiratory tract infection in a nutritionally at-risk picky eating children in India. They were around the power of around 250 children. The study showed that nutritional intervention of ONS and diet counseling in nutritionally at-risk picky eating children helps to maintain their weight during acute infection, and use of ONS is effective for improving the nutritional status as measured by the weight for age and BMI for age, and it enhances protection against relapse of upper respiratory tract infection over the intervention period. And India has a considerable health, economic, and clinical burden of child undernutrition and respiratory tract infection. The findings suggest that long-term nutrition intervention that measures the health economic impact of ONS on child's growth and infection is required. This study investigated the efficacy of zinc and vitamin A in treating pediatric community-acquired pneumonia. The results were as expected. The supplement led to a significant decrease in hospitalization length in this population. And in comparison to the control group, they had shorter mnemonic effusion duration. And these findings highlighted the potential of zinc and vitamin A as valuable additions to standard community-acquired pneumonia treatment regimens, potentially leading to improved clinical outcomes. So, a diet with high protein, dietary fibers, medium chain triglyceride, probiotic, omega-3, and micronutrients, which are present in oral nutritional supplements, should definitely be helpful in this scenario. So, summarizing, pneumonia is the most common under 5 problem. Combination of fever and cough is suggestive of pneumonia, but presentation may be subtle. Radiographs are not necessary when you're treating it as outpatient in resource crunch situation. Routine laboratory evaluation is also not necessary in mild cases. Always hospitalized in children less than 3 months. 2 months to 5 years, amoxicillin, co-amoxiclav, cephalosporins are the drugs of choice. More than 5 years, amoxicillin, co-amoxiclav, cephalosporins, and macrolides, I've told you when to introduce. Supportive care and follow-up for both out and in patients are necessary, and oral nutrition supplement to improve immunity and for quicker recovery. So thank you all for the patient listening. I'll now throw the session. Sorry, I'll just hand over the session back to the moderator.
Yeah, thank you so much, Dr. Karthikeyan. It was a comprehensive way as to how to approach a child who might be suffering from community-acquired pneumonia. And definitely, nutrition also becomes one of the most important pillars when it comes to the overall management of kids suffering from any acute illnesses like pneumonia and other things. Thank you so much once again. Now, what happens if the pneumonia becomes very severe and requires a critical care? So let us learn from Dr. Namit Zirath as to what are some of the modalities of treatment and approach and in case of acute respiratory distress syndrome, and what are the major things which we need to consider as.
Okay.
What do you say?
Can you see my screen?
Yes, we can see your screen and we can see you also. So is there any way you can make it full screen, sir?
It is full screen on my end. It's not full screen there, is it?
No, sir, it's not full screen.
It's both same.
Okay, let me stop and share it again.
Yeah.
Yeah. Yeah. Yeah, that I've clicked. Okay, let me just go back and I'll do it again. Just give me a second.
Yeah, so the way we did it in the dry run, sir, same.
Okay, right. Oh,
Yeah, allow sir to do it, please.
is it okay now?
No, sir. I mean, the way you did it during the dry run, we could see the entire screen, but now we can see half the screen only. So if you can share only the presentation, not the full screen.
नहीं मैंने right.
Now you did.
Yes.
Now
It's perfect. Now it's perfect.
So, thank you, Signatra, Dr. Atul Mishra and the team. And sorry for this glitch. I thought managing ICU was difficult. But anyway, and first of all, I think Dr. Karthikeyan has done an excellent presentation, and it has made things so much easier for me because what I am now going to do is give you a slightly different perspective of things when things actually go out of hand or worsen and go into a situation of a more severe respiratory distress or respiratory infection. I will go through a case talk about the various aspects of treating a child with acute respiratory distress syndrome, and then just touch on the nutrition aspect and leave it to the experts and Dr. Anita Jatana later on to discuss about that in bit more detail. So, okay, so this case is 11-year-old child who started off just like the case which Dr. Karthikeyan discussed, fever and cough going on for 4 days, respiratory distress which started for the last 2 days. He was seen by a pediatrician, started on some treatment, but he continued to worsen. And with the worsening distress, he was referred. And in the emergency department, he was in distress with a heart rate of 140, respiratory rate of around 45, saturating 91% with 6 liters of oxygen by face mask. And the blood gas done in the emergency department showed a pH of 7.32, CO2 of 38, O2 of 62, bicarbonate of 17, and lactate of 2. So not a very bad gas, but you'll do an X-ray, and this is a story of just about 5-6 days, and the X-ray shows diffuse bilateral infiltrates on the lungs. So it's just a rapidly worsening pneumonia, which has caused the child to have diffuse infiltrates in both sides of the lungs, and his oxygen requirement is worsening, though the blood gas as of now is still okay. And in the next 3 days, you have the blood gases on the top, and you can see that the gases continue to worsen. The pH went from 7.32 to 7.2 and then 7.1 by day 3. And the carbon dioxide kept on rising from 38 to 59 to 87. This is in spite of increasing ventilatory requirements. So from day 1 to day 3, the child is on much higher ventilatory support, still needing much higher oxygen concentrations, and has a worsening blood gas. So obviously, the child is not improving, is worsening, and that is very obvious on the X-rays there as well. You can see the X-ray on the top, which shows a good going pneumothorax on the left side, good infiltrates on the right side. The child is intubated, has an intercostal drain inserted, and by day 3 after intercostal drains on both sides, you have diffuse infiltrates, a child on ventilator with bad lungs, bad gas, and a very high ventilator support. So is this ARDS, right? So this is a very typical story of ARDS. There's a history which is suggestive that something has happened and happened in very recent past. There are infiltrates in the lungs, usually both sides. Usually the heart is not a culprit, so you exclude heart being a culprit, and hypoxemia or oxygenation remains a big issue with these scenarios. So this is the typical story of ARDS, which this child also had. And this was actually defined as ARDS or explained as ARDS long back in 1967 by Ashbaugh, where they compiled the post-mortem reports of around a dozen patients. And even in that series, 3 of them were adolescents. So it was recognized as a disease of refractory hypoxemia with non-cardiogenic pulmonary edema in this patient population, where hypoxemia becomes very significant. And this was, they coined the term, though they had a few adolescents, they coined the term ARDS as adult respiratory distress syndrome. But now we know this is equally common or equally prevalent in children, and A stands for acute rather than an adult respiratory distress syndrome. And in 1994, the first consensus definition of ACC came up, where they compiled all these features and came up with the definition where it had to be an acute onset within the last 2 weeks, bilateral infiltrates on the X-ray, you excluded cardiac involvement, and then you had some markers of hypoxemia or acute lung injury, which is causing hypoxemia, and there were various categories or categorizations depending on what we call as the PF ratio or the PaO2 by FiO2 ratio. So how much FiO2 are you requiring to get that PaO2? So this definition was actually being used across the pediatric and the adult world for a long time, till the PALIC or the Pediatric Acute Lung Injury Consensus Group came up with the set of guidelines first earlier in 2000s, and now a revised one in 2023, which is known as the PALIC-2 guidelines. So this is the current guideline of pediatric ARDS diagnosis and management, which has been published just last year in February and is now the benchmark for the diagnosis and management of acute respiratory distress syndrome in children. So this guideline has refined the diagnosis. So the definition, and you would see our child or this index case fits into all these definitions. So this is a age-wise, this is a patient with does not have a perinatal lung disease. It has occurred within 7 days of a clinical insult. So not 2 weeks, which the earlier guideline said. Now we consider 7 days. The origin of edema is not cardiac. So you know that it is not cardiac failure which has caused the lung edema. And on chest imaging, you have neopicities, either unilateral or bilateral, which excludes pleural effusion or atelectasis. So new alveolar parenchymal infiltrates on the chest imaging. So these are the basic criteria that you need. Plus, the main problem in ARDS is oxygenation defect. So hypoxemia or reason or some measure of oxygenation defect is important to diagnose ARDS. So depending on whether the patient is on invasive or non-invasive mechanical ventilation, there are various criteria. We talked about this PF ratio, PaO2 by FiO2 ratio, but another important aspect of diagnosis or classifying hypoxemia is by the use of this OI or oxygenation index, which is the mean alveolar pressure multiplied by the FiO2 by the PaO2. Now, if you look at this, this is not just the PaO2 and FiO2, but also takes into account the ventilator settings that you're using. So if you're using a higher ventilator settings to get a good PaO2 on a lower FiO2, you still have a higher oxygenation index. So it is considered to be a more complete assessment of the hypoxemia. So now the definition classifies the pediatric ARDS or PARDS into two, the IMV, invasive mechanical ventilation, or the non-invasive mechanical ventilation PARDS, and then it is subdivided in two groups, mild to moderate or severe. So mild and moderate is one group and severe is another group. And these are the various cutoff criteria which tell you whether the child is going into a severe ARDS or is in a state of mild to moderate ARDS. The other important thing is that they have decided or recommended that the severity classification should be delayed at 4 hours, which means the patient presents to you, you do your initial bit of resuscitation, management, ventilation, and when after 4 hours, the status after 4 hours defines the severity of the disease, which means the child might actually come in very sick. And once you have intubated, given oxygen, started on some supportive treatment, by 4 hours, the child would have stabilized enough to give you an idea of the severity. And the 4-hour severity classification has been shown to be more aligned with the risk of mortality. So this mortality discrimination is better when this severity stratification is done at 4 hours rather than on presentation. So that is the definition of ARDS or classification of ARDS. So ARDS it's not uncommon, varied incidence, depending on the patient population, the type of settings you are. If you work in a tertiary care hospital, which has a very active or very busy, let's say a bone marrow transplant program, the incidence might be very different. But in a study from AIMS, there were about 20 per 1,000 PICU admission incidence of ARDS, and the incidence ranges from 8 to about 25 in most of the PICUs. The mortality of PICU ARDS is to the tune of 35 to 50%. So this is a significant mortality. And in spite of the advances and improvement in the intensive care, this mortality has not really changed beyond a certain limit, even with significant improvements in our care. The advantage for us as pediatricians is that the younger children tend to have better outcomes. So ARDS can be because of a direct injury to the lung, which is usually the most common scenario for children who are coming from the community. So pneumonias, aspiration, pulmonary contusion, fat emboli, where the lung is directly involved. And sometimes it could be an indirect lung injury where the origin of the infection or the origin of the inciting agent is not the lungs, but somewhere else. Sepsis, pancreatitis, transfusion of blood products. So something which is not the origin of the infection, but lung being involved as a bystander. So the pathogenesis, and this is important to understand in terms of treating the ARDS. So you have on one half of the picture, you have a clear alveoli, and the second half, you have an alveoli which is filled with debris. There are a lot of exudates, there is fluid, there's activated neutrophils, lots of cytokines. This alveoli and the inflammation with it tends to affect the alveoli and the endothelium, which is just next to the alveoli. So this becomes a disease of the alveolo-capillary membrane. So both the capillary and the alveoli is affected severely, and this becomes the main reason of hypoxemia or a problem with the gas exchange in the alveoli. So ARDS progresses through these stages. There's an early stage of first 2 to 3 days where there's acute exudative inflammatory infiltrates in the alveoli. Over the next week, 10 days, it becomes subacute where there is a proliferative phase, and then sets in a state of a chronic fibrosing alveolitis stage where there is fibrosis and increased worsening of gases. So you can see the infection happens in the acute stage. And after that, the infection might be controlled well with your medications or your antibiotics or supportive care, but the hit has happened and the lung tends to go through a phase of healing and fibrosis, and you continue to have the effects of all the alveolar damage. And this is probably where nutrition and healing and body's own immunity comes into play in a huge way in recovery and healing of the children. So how do we treat that? So what we know now is there are some certain concepts which are very important in treating children with ARDS or treating anyone with ARDS. One very common concept which has been popularized a lot by Gattinoni and all is the baby lung concept. So what we know is that it's a heterogeneous disease. There are patches of lung which are severely affected, and there are patches of lung which are relatively spared. So if you think of the whole lung, there is a part of the lung which is relatively spared, which is a baby lung or a smaller lung. And we tend to focus on that lung. So rather than trying to ventilate and make the whole lung do work, we focus on that part of the lung which is relatively well. So you can think of it like if you fracture your forearm, you would put it in a sling and not make it work. Rest it. If you have stomach pains, you go slow on what you're eating. So give your stomach some rest. When your lungs are infected, we tend to push the lungs more and more. That is not right. We need to somehow try and give rest to lungs as much as possible. And that's the idea of a baby lung disease. So the pathophysiology decides our treatment. There is decreased compliance. The lungs, they are heavy. They are not that flexible. So you now need more effort, more pressures to move air in and out of the lungs. There is alveolar edema, which makes lungs more heavy. It's like sponge dipped in water, soaked all the water. Now it's become heavy. It's a heterogeneous disease. So ARDS is heterogeneous in just about every way. In the causation of it, the inflammatory state, various parts of the lungs might be at various stages of inflammation. The pathology can be heterogeneous, and the recruitability, how easy is it to recruit the lung, is very heterogeneous. So you have the same child, same lung, but various parts of the lung have various heterogeneous levels of involvement. So one prescription obviously doesn't fit for all. And baby lungs, obviously, we have discussed. So the principles of management depend upon these pathophysiology. Hypoxemia is the hallmark of ARDS. All children in ARDS, the biggest problem is they are hypoxemic. And all our respiratory management targets or efforts are targeted towards preventing or reducing this hypoxemia, at the same time preventing lung injury. So it's a balance that we have to do. We have to prevent hypoxemia, or treat hypoxemia, but while we are doing it, we cannot just keep on battering the lungs over and over again, which will cause more and more lung injury. So our respiratory management focuses on adequate oxygenation, not generous oxygenation, just adequate oxygenation, adequate ventilation, very importantly, prevention of ongoing lung injury. So we try and prevent all types of trauma. So we do what we call as baby lung treatment. So you treat the lungs as only small lungs. There is a concept of open lung, which I'll talk about. There's a concept of permissive hypercapnia. Now that you are ventilating the child at lower pressures, your CO2s will be high, and that is okay. You accept that. And to certain degree, even permissive hypoxemia, where you allow even the oxygen saturations to be slightly on the lower side. So the whole thing in total, trying to do the least damage and maintain some degree of oxygenation and ventilation is what we call as gentilation or gentle ventilation. So this is the principle of all the respiratory management. But it is important to remember that it is not just the respiratory management. There are so many important non-ventilatory managements, including hemodynamic support, nutrition, that is supposed to be our topic for today, the metabolic sugars and electrolytes, the infections, fluids, all of this remain very important in the management of ARDS. We are very careful. We titrate the fluid balance literally hour to hour to maintain a child in right fluid balance so that the lungs don't get flooded, don't get heavy, and they remain as crisp as possible. So the principle of ventilation is, depending on compliance, you want to use pressures, you make changes in the pressure to get a change in tidal volume. And we would want to do those pressure changes in what we call as the safe zone, where you do the least amount of pressure change to get the most amount of volume change. So the biggest bang for your buck. So that is the whole idea of ventilation. And when we do ventilation, we try and find this zone of safe ventilation where we can get the most advantage of tidal volume change with the least change in pressures so as to prevent injury. And the easiest way to do that would be to restrict the tidal volume. So rather than giving very high tidal volumes, if we give lower tidal volumes, it would help, right? So this is what we know as the low tidal volume strategy. So the ARDS-NET trial, which is a very famous trial, almost like a Bible of a trial for anyone doing intensive care. It's been more than a quarter of a century that this has been around, where the investigators investigated 12 cc per kilogram versus 6 cc per kilogram and looked at the mortality. And just by having the tidal volume from 12 to 6 ml per kg, there was almost 20% reduction in the mortality. So just one ventilation strategy change caused a significant change in the mortality. And this has become almost a standard practice of using same tidal volume, lower tidal volume. So what happens in the lungs is what you see here. This is just a scope at the level of the lungs, and you can see the alveoli are opening up with each inspiration, and with expiration, they go smaller in size, but they do not collapse. And let us look at another area. This is an area of the ARDS lung, where you can see the alveoli some are opening, some are not opening. There's a lot of interstitial edema or thick areas. And then as the pressure goes up and up, some alveoli you will see keep popping up on your screen. So some alveoli open up at lower pressures, while some alveoli need much higher pressures to open up. So some alveoli are opening at lower pressures, some are collapsing with each breath, and some need much higher pressure to open up. So again, something to remind us that this is a disease which is very heterogeneous. So now what we need to do is we need to open up these alveoli and then keep them open. So this is what we call as the open lung concept. So on the ventilator, we use the positive end expiratory pressure to keep the alveoli recruited. So we will use pressures to open up the lung. And once they are open, we continuously use a pressure, which is called the positive end expiratory pressure, to maintain the lung in a partially distended state so that we prevent it from collapsing with every breath and prevent the atelectotrauma. There are various ways of deciding what is the right PEEP and what is the right way to use this open lung concept. And there are also other ways of using different ventilatory strategies like high frequency ventilation to do the same thing. I spoke to you about hypercapnia. So some people call it not just permissive, but submissive hypercapnia, because the situation is so bad, you have to accept whatever CO2 you get. So as long as the CO2 is not causing harm to the child, we would accept it. So there's no upper limit that we would accept. We will accept whatever gives us adequate hemodynamic and other status of the child. So we would be happy with even CO2s of 90s, 80s if the child is otherwise well. And there's actually a study where they say that this hypercapnia, which is associated with these gentle ventilation strategies, may actually be protective. It's not just that it is helping with lower tidal volume strategy, but it is actually protective in terms of reducing the spread of inflammation. Sometimes, in spite of your best efforts, there is refractory hypoxemia. The oxygen levels just don't improve. And then there are other options that we keep doing. Very common ones are prone positioning, which is very easy to do. It can be done at any place where you're doing ventilation, and it has very good dramatic effects. Other options are use of inhaled nitric oxide, advanced modes of ventilation like high frequency and APRVs, or in some really, really advanced stages, extracorporeal membrane oxygenation or ECMO. So high frequency ventilation is essentially nothing but trying to use very high pressures, but very low tidal volume. So it's like supranormal pressures, but very, very small tidal volume so that you minimize the trauma to the lungs with these ventilation. But prone position has really helped many children and many patients with ARDS, especially in the last 10 odd years, since we have started using a lot of prone positioning. When you turn the child prone, you move the dependent area of the lung to a more non-dependent area, and all the consolidation or the gravitational fluid tends to seep down to the ventral surface. And now this dorsal surface, which is a huge area of lung, is available for gas exchange, and it reduces the ventilation perfusion mismatch. And prone positioning in acute ARDS was shown to have improved outcomes in the prone group compared to supine group in adults with severe ARDS. So this trial again reinforced the benefit of prone positioning. And as I said, rarely you would need the support of extracorporeal membrane oxygenation or ECMO, which fortunately now is available at many centers, and it is though it is expensive, but it is not as expensive as it used to be probably about 5 years back. It is becoming more and more affordable. ARDS, as I said earlier, still has a significant mortality, and the mortality is usually due to multi-organ failure, which is probably triggered off from hypoxemia. But the better thing to look forward as pediatricians is that most children who survive ARDS don't tend to have long-term sequelae, unlike adults who tend to have some very long-term side effects. So this PALIC-2 guideline has given us recommendations, not just for the ventilatory aspect or targets of what to use or what to target with various ventilatory strategies, but also what to do for non-ventilatory strategies. So how do we manage the pain, agitation, the sedation, the neuromuscular blocking agents, the fluids and blood, and nutrition. So the recommendation in terms of nutrition is that you should start early. Start definitely within 72 hours, and you target to have a protein of more than 1.5 grams per kilogram per day. So that is the target of nutrition that you would want to have in children with ARDS to help with their recovery. So just to finish off, I go back to our case. So this child grew Staph aureus, which was a methicillin-sensitive Staph aureus, and he was started on appropriate antibiotics, but he had multiple pneumatoceles, lots of air leaks, needed bilateral chest drains, and needed prolonged ventilation. This ventilation, prolonged, bad lungs, meant that we had to ventilate him for a very long time, for almost 6 weeks. He underwent a tracheostomy, had problems with all the sepsis and infection and ventilator, and required and developed this ICU acquired weakness or ICU acquired polyneuromyopathy, and which usually means that it's a very slow, painfully slow progressing state which you have to deal with. We did manage to establish enteral nutrition by about 48 hours, which we try and target for most of our PICU patients, unless there are some absolute contraindications. There were many challenges with the tolerance of feeds, but we were able to manage. And this child did relatively well, was discharged with a tracheostomy. Thank you so much for your listening.
Well, thank you so much, Dr. Namit. I think that was a very comprehensive, very insightful. A lot of learnings were there as when it comes to the PICU management of kids suffering from ARDS. Now, ma'am, Rita, ma'am, I would. Are you there, ma'am? I think she's lost connection.
Yeah, I know I'm there. Just screen share.
So, ma'am, Dr. Karthikeyan as well as Dr. Namit has shared their cases when it comes to the community-acquired pneumonia and when it becomes a severe case of ARDS from a pharmaceutical as well as supportive care or ventilation modes of care for the kids. Now, I'm turning to you to guide us as to suggest that does a good nutrition have any role in terms of kids who are hospitalized because of pneumonia or kids who are in ICU, in PICU? Does that good nutrition really help in terms of the recovery? Does it also help in terms of maximizing the treatment responsiveness from all those pharmacological and antibiotic therapies which doctors have shared? So turning to you, ma'am.
Yeah, just can you see the screen?
Yes, ma'am, we can see your screen.
Yeah.
We would like to see you also, if possible.
Just a minute. Is it fine? Audio, video?
It's all fine, ma'am.
Yeah. Okay. Thank you. Thank you for this opportunity. And I think it's life is really easy with two stalwarts before me talking in detail, and they've supported what we do as nutritionists. Role of nutrition in pediatric respiratory care is important. So, and Dr. Kerath also showed beautifully in the last two slides, when you do everything together, the occurrence, reoccurrence, and improvements are much better. So they definitely do better when it's all together. But just to start giving it you a nutshell, I'll say I think we all know it. Respiratory failure is the ineffectiveness of the respiratory system to fulfill the oxygen requirements and or effectively excrete carbon dioxide from the body. So there are various reasons for it. The prevalence is high among children, more in children than in adults. And we've seen it more, as you just heard, in malnourished children more than people who are well-nourished. And of course, it's community acquired and also due to various reasons. Acute respiratory distress syndromes accounts to 1 to 10% of the PICU hospitalization, and ARDS reported in reports was 20.1 per 1,000 admissions with a 75% death rate. In most cases, pneumonia was discovered to be the underlying reason. Reasons, consequences, of course, includes neuron and other aspects, cellular aspects. Common causes is pneumonia. And I think Dr. Jarrett will support when these people get admitted. These are the various diseases they get into. Asthma, tuberculosis, we have cystic fibrosis, we have pulmonary edema, respiratory infections, and vasculitis, which lead to all the problems. Malnutrition is acquired in 50% of those patients already in the pediatric care unit, with the added burden of nutritional deficits worsening, which is already there. So you have a malnourished child and then he's got an ICU, so it only worsens the situation. Nutrition forms an essential component. I think we all agree on that. And reduced immunological responses due to critical illness, atrophy, and increased intestinal epithelial barriers permeability results in increased susceptibility to infections and the spread of pathogens. So that's the way how nutrition is going to affect and worsen the situations. There's impaired glucose tolerance. You'll see it all in your patients there. Increased lipid breakdown and altered protein metabolism are all indicators of catabolism and systemic inflammation. What? Fine, so I got stuck, sorry. So what are our goals as a nutritionist? Make sure that nutrition should form an essential component in managing respiratory conditions with the potential to change outcomes. Adequate calorie intake. We can't do either overfeeding or underfeeding because it all has problems, and we'll discuss it in detail as we go along. Demands on critical illness. If we overfeed or underfeed may expose children to malnutrition or metabolic load. So we have to be very sure, and the window is very small on how much calories we give to these patients, and then obviously divide to the other macronutrients. Adequate protein intake, you heard Dr. Jarrett talk about it. Correction of the cause of respiratory failure. Avoidance of excess carbon dioxide production. There are studies which have said which can be achieved by lowering the carbohydrate intake. However, a balance of carbohydrate and fat ratio is recommended. So we definitely, earlier before these protein supplements were there or nutrition supplements were there, when we couldn't meet the calorie loads in small volumes, I think we all used to just put oil and sugar to make sure it happened. But that's absolute history. Nobody is doing it now, and recommendations are to go slow on pure sugars for these particular patients because of the more carbon dioxide production. Reversal of nutritional related sequel of lung disease, which includes optimization of exercise tolerance and normalization of growth, which is very critical for these particular subset of patients. So nutrition care process, what do we do? Very, very clear. The moment the patient gets admitted, patient screening is mandatory for everybody, not only in ICU, for everybody. And we are a JCI accredited hospital, so it's mandatory for all patients, not only ICU, but all indoor patients. Assess those patients in detail, calculate what they actually need, and then make sure that the implementation happens. And then keep assessing and reassessing and changing your calorie nutrition goals as the patient's needs change. So it's an everyday affair, especially more in the ICU scenario. ABCD of nutrition, anthropometry, very, very simple. MUAC, skin fold thickness, weight, height, which are done the moment the patient gets admitted in every hospital. Head circumference, calculate the BMI. So even a simple test like this will tell us what is the status, nutritional status of these patients, and how aggressive do we intervene with these patients. Where does he stand in the Z scores? And you have those charts, growth charts, just calculate that and we know where this patient stands. Pre-existing malnutrition, clinical, underlying disease, recent weight loss, Couple of questions. Did he lose weight within a week, or has he been underweight over a long period of time? Will tell you what was the nutritional status of this patient. Was it acute or is it a chronic problem? Biochemical assessment, you heard in detail what all is done. From our aspects, we do look at protein levels, albumin. Still, we are looking at, because though every study tells you that albumin is not a very good indicator to tell you his nutritional status, and it is still being done. Transference, CRP, macronutrient deficiencies in case required, then they are done in details. Otherwise, supplementations are done. And vitamin A, D, E, K are very, very important. And then the electrolyte balancing act is definitely there. So adequacy of previous and current nutrition intake. So we meet the patient or the attendant, obviously attendant in this particular case, assess where he was and how it compares to the RDA of that child. So a quick nutritional intake will tell you how good or bad was his intake over the last week, or was it just for a couple of days? Is he vomiting? Is he tolerating food? Or does he have any allergies? And all these things should be noted on his chart so that we don't make an error when we are calculating or planning his particular diet. Does he have any allergies? Should be flagged and made sure that those things do not worsen the situation while he's in ICU. We do look at religious, cultural, and personal preferences, though that especially religious, because we can't be giving eggs to patient or gents who will be not be offended by it. So all those are taken into care when we do the care plan. So definitely, there are lots of nutrition screening tools which are used to identify malnutrition or change in risk of malnutrition of these young children. Height for age, these, I think we are all very, very aware of these. And weight for height, Z-scores or percentage of expected value provides a measure of the degree of under or over nutrition. Both are harmful. So we know that if you have an overweight child or an underweight child whose BMI is less than 18 or more than 40, they're both in the high risk category. CPM or acute protein energy malnutrition, again, these are forms, and use the Waterloo stages, which categorizes it very well. All forms are there, and we can refer to them to just tell us where the nutritional status of these patients are and how aggressive our intervention should be. Skin fold thickness, I think all of this can be done very, very easily, takes no time, takes no money, and should be done. And should be done even in the OPD, for OPD patients also. So which will help us to actually understand the fat deposits and the muscle mass, the lean mass, which category he falls in. The indirect calorimetry, of course, every book, every paper will tell you that, yes, it's the gold standard in nutritional assessment. It will give you the right, accurate calorie requirements, which sometimes get over-assessed or under-assessed when we use formulas. But I don't think this is being used in more than maybe 5% of the hospitals across because of the costs involved. So we definitely still go to our formulas that we use. Subjective global nutrition assessment is another tool, very simple, few questions to ask, which will again help us. So any particular form that you want to use in your scenario, just adapt to that and make sure that it happens for everybody. The STAMP screening tool, very, very simple with just 4 questions and you are there. Did he lose weight? Is he eating well? Just 3-4 questions and you have your assessment done. For the children, these 2 assessment forms have been really recommended. One is Strong Kids and STAMP screening tool for assessment for hospitalized children to decrease complexity of previously available stoops. So these are very simple, not even a minute each on each particular tool that you can do. And the PNST, which is again a pediatric nutrition screening tool, developed to improve simplicity of nutritional screening in hospitalized patients. Again, just is he eating? Is there been a loss of weight over what period of time? And how active is he? And is he vomiting? So just a few questions and we are there. So just to show you what these screening tools look like. Simple questions. You just have to do tick, 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 and you are there and you know which particular risk, what is his risk score. and how aggressive your nutritional intervention should be. Just to show you a couple of them, but they are all available on Dr. Google will help you, all of you, to get these forms downloaded and use them in your hospitals. So when to initiate EN? Sure, yes, obviously, give the child the first opportunity to eat. But if you find that his oral intake is not adequate, then and do try ONS. If you think by doing that also, if you can avoid putting the tube, you can do that. But if you find that inability to eat 60 to 80% of the individual requirements for 10 days, or he's not going to be meeting it over the next 2-3 days, start with the isotonic feeding initially. Avoid making simultaneous changes in volume and concentration together. And we'll discuss the EN in detail. Increase volume before concentrating with and administrating transpyloric feeds. Advance concentration before volume with gastric feeds. If feeding intolerance develop, return to the previously tolerated route. So it's a two-way process. Step a little, advance. If you find he's tolerating, keep on stepping up. And if unable to reach, then add supplements as and when required. I think we all know this. We have the nasogastric, nasoduodenal, and nasojejunal. Depending on do we want it for a short term or for a long term. And if he has other medical problems, then you choose which particular site you want to use for initiating enteral nutrition for these particular children. So we know the importance. EN is definitely better. If you can't do EN, then parenteral nutrition is advised. You know there is a translocation of bacteria if EN is not introduced fast. And I think Dr. Nami just said within 72 hours, it should be initiated for these particular patients. Enteral nutrition, the first thing was if the gut works, use it. But now the protocol is if it does not, make it work. Make it work how? Some magic? Initiate with tropic feeds. Small amounts, 50 ml per kg per day. That's it. Few spoons. And initiate with just 1 to 2 ml per kg per hour. And then gradually advance and increasing it by 0.5 to 1 ml as tolerated over 8 to 12 hours. But even if you give that little small amount, you will be able to stop the translocation, which is so important, and you'll be able to maintain the gut integrity. You can do either bolus or intermittent, but depending on how critical the patient is, you can do continuous if it's very critical, or you can do tropic feedings. So begin at 25% of the goal on the first day after you've done the calculations. Divide formula equally between 5 to 8 feedings and increase by 25% as tolerated. So if you've reached your target goals by 7 days, I think we've really achieved the best that we could do for this particular patient. So modes of delivery. So they're very well given there, and you can see this has been taken from the enteral nutrition in pediatric patients, pediatric gastroenterology hepato journal. So anybody can refer to it, how to bring up, and this is given very well from 0 to 12 months, 1 to 6 years, more than 7 years. And they've also compared it to the continuous feeding and how to advance as we go along every 4 to 5 hours. So it becomes a very easy referral for all of us on how to pick up these patients. Fluid calculations. So once we've said, okay, we are going into enteral, we decided we are going to give him enteral nutrition, then we have to decide on the volumes. So these is the volumes, and we just discussed on how we will break it up for them and which particular mode you would want to do. So this is the guidelines, 0 to 10 kg, 100 ml per kg is the volumes that you would do, and divide it during the feeds during the day, 5 to 8, depending on how you want to do it, or continuous using a pump if required. Contraindications to enteral nutrition. Yes, sometimes you have to resort to PN when you have bowel stenosis, severe diarrhea, gut ischemia, decompensated shock, severe acidosis, uncontrolled upper gastrointestinal bleeding, bowel obstruction, abdominal compartment syndrome, or a high output fistula. So if any of these particular problems are there, however eager you are to initiate enteral nutrition, you will have to wait, address these issues, and then probably do it later. So this is very well given here, and this is again taken from the nutrition therapy and critical illness guidelines. Start early nutritional, this says within 48 hours, preferably even 24 hours when there's no reason to delay enteral nutrition. So I would say the moment the patient is stable, you stabilized him, definitely start enteral nutrition. It's associated with lower risk of infection and preserves the gut function, immunity, and absorptive capacity. Delay early nutrition in case of obstruction because it will lead to blowout or perforation. Delay early nutrition in case of compromised splenic circulation such as uncontrolled shock, bowel ischemia, abdominal compartment syndrome, during intra-abdominal hypertension, and feeding increases abdominal pressures. So absorption of nutrient demands energy and oxygen in states of low flow or in ischemia, forcing feeding into ischemic gut may aggravate ischemia and lead to necrosis or perforation. So they are rational why we are saying what we are saying. Delay early enteral nutrition in case of high output fistula. I think we all would support that. Enteral feeding will be spilled into the peritoneal space or increase the fistula production. Delay early enteral nutrition in case of active gastrointestinal bleeding. Again, no controversies on that. And delay early enteral nutrition in case of high GI residual volume. So if you had that, you still would try with using prokinetics, and post-pyloric feeding can resolve this problem to an extent. So the 6 point can be addressed if we do it. And these are the barriers. So feeding children is difficult, not to say that the adults are easy because they are fussy, but children are worse. So they, even if they've had one nausea or vomiting, they are scared to try eating again. So they are really scared at that particular time. And that's the time maybe putting a tube again would be difficult, but Dr. Namit would probably help us with that. So children who are critically ill often experience feeding difficulties due to perceived feed intolerance and interruptions in feeding. And we've had also the adults tell us that after a particular feed, he felt bloated, and we had to actually measure gut for them and say it's the same gut. So it's nothing to do with feeding. And those are the types of convincing some patients need. Fluid restriction may be required, gastrointestinal intolerance, obviously if there's vomiting, gastric residuals, or diarrheas. Diarrheas can be mostly resolved with changing the feeds. Sorry. Interruptions for procedures, which definitely happen, hemodynamic instability, fear to induce intestinal complications, and poor protocols in some places. So 50% of patients achieve full ER by day 7. So that's the only percentage that actually reach. This is a huge gap. So despite so much of knowledge, so much of effort, we still have a huge hurdles. Sorry. I'm so sorry, just recovering from a bad throat. As I discussed, if you have problems, you can use prokinetics. I think that is done by the medical team. We don't advise it. Continuous enteral feeding via enteral feeding pump. The recommendation of DR, most hospitals have adapted to that. Bowel stimulation, again using erythromycin, or use peptide-based formulas. We've seen very good results using peptide-based formulas. They are easier to digest for some patients. And post-pyloric feeding, jejunal tube placement, and continuous enteral feeding without the night pause can be the recommendation for these patients. So now optimal energy delivery. Energy delivery varies significantly during the PICU stays. So acute start lower end in the acute phase and gradually introduce and go up higher. As we said, indirect calorimetry is the best method, or energy targets can also be estimated optimally using the oxygen and carbon dioxide volumetry calculations. This is the best formula, though Harris-Benedict's equation is also being used, but we found there's a lot of error between the calculations. So this is the one which shows the least error, the Schofield formula. Again, very, very simple to calculate, as you can actually download that app and you can just put the A weight and you got the calorie calculations per day and then divide it according to the volumes you have or the target that you start from, and then reach your target goals within 7 days. Carbohydrate delivery there should be sufficient to meet metabolic and energy needs without causing overfeedings. This is very important. We, as I said, can't have underfeeding or overfeeding in these patients. The normal carbohydrate delivery should be between 55 and 60 of total calories in ICU. But a low RQ can be achieved in pediatric patients with a diet slightly lower in carbohydrate content, 36% of the total calories, in a patient who is compromised or has issues here. We discussed how carbohydrates should be at a little lower end for these patients. Optimal protein delivery, an important goal for protein delivery is to prevent a negative protein balance. The recommendations we heard was 1.5, and you can go up to 2.5 and 3 in a patient who is more sick. But again, it has to be graded very gradually and don't be very enthusiastic and start very high. Start at a lower level and achieve your calorie goals and protein goals. Lipids again, 1 gram of liquid we all know contains 9 calories. Lipid energy should be between 25 and 50% of the non-protein calories. Important component. PICU overfeeding, we just discussed. Excess carbon dioxide production and increased minute ventilation, pulmonary edema and respiratory failure, hyperglycemia, which may increase infection rate, lipogenesis due to increased insulin production, and hepatic complications, fatty liver, and intrahepatic cholelithiasis. So we have to now look at refeeding syndrome. That's why we said let's not be over enthusiastic with these patients. During poor feeding or starvation, energy is derived from ketone bodies derived from breakdown of fatty acids to avoid breakdown of muscles and proteins. Intracellular muscles are also depleted, minerals, are also depleted. With refeeding, there's an increase in blood sugar and synthesis of glycogen, proteins, and fat, which requires potassium, magnesium, and phosphorus. So when we are starting a patient on feed and he's been in NBM for a very long time, these minerals should be really monitored very closely and supplementation started when we start with refeeding these very starved patients or nutritionally depleted patients. This results in further severe depletion. So once you've given them a supplementation, they'll do fine. It happens after 4 to 5 days of refeeding, and a child who has lost weight rapidly is at high risk. So role of micronutrients in immune and pulmonary functions. I think all of them are very important, but I will just go over the main ones. And there's been a lot of studies which have supported also for pneumonia. That vitamin D, they found very, very helpful, and people who got pneumonia were vitamin D deficient. So vitamin D is known to downregulate pro-inflammatory cytokines and increases the Th2 cytokines, contributes to the maintenance of the Treg cells. It increases expression of antimicrobial catalycidin. So these are important. Vitamin A is an anti-inflammatory antioxidant, maintains cell proliferation, and very important again for these patients. Vitamin E, we all know, is again a very important anti-inflammatory antioxidant. Deficiency is associated with an increase in inflammatory cytokines. Consistent of lung surfactant deficiency has been associated with a pro-apoptic state of type 2 lung cells. Vitamin C, we all, I think, took a lot during COVID times, and a lot of studies have supported supplementation vitamin C as an important antioxidant, as a cofactor for enzymes is present. So again, recommended for these patients. Selenium, zinc, we discussed. Omega-3, we just heard, very important again as an anti-inflammatory. Folate, Vitamin B12, B6 deficiency is associated with decrease in proliferation of lymphocytes. Thiamine, vitamin B12, copper, cofactor for enzymes, and riboflavin, cofactor for enzymes that participate and regulate oxidative stress. So all these are required. I think giving the multivitamins in the right doses is important for these critically ill patients during their stay there. So these are the referrals on the recommendations, RDA. These are latest from 2024 guidelines. So recommendations are very clear for these patients. Again, linoleic acid, alpha-linoleic acid, calcium, copper, iodine, all very, very clear. These are the latest. So types of enteral nutrition formulas for them, we would, for a normal patient, we would start with polymeric formula. If not tolerating, then we would start with semi-elemental, or if he's too critically ill, we would start with elemental and then take to polymeric formula, depending. We have specialized formulas, and for patients who can't afford it or who are also going home on tube feeding long-term, not because of lung issues, but other long-term issues, can be taught for home how to make kitchen feast. But it's very difficult to achieve calorie and protein goals because the thin tubes can barely take in 5 grams of any proteins into that. And we don't want to give too much of milk because of lactose intolerance in these patients because of the heavy antibiotics that they are on. So takeaway message, malnutrition and the presence of pulmonary disease have been demonstrated to cause structural and physiological changes in the respiratory system. And assessment of nutritional status is very important, imperative upon admission to the PICU, as is the identification and assessment of acute or chronic lung disease. In patients with pulmonary disease, it's important to adapt the macronutrient distribution with a slight reduction in carbohydrate intake, age-appropriate amount of protein, and a slight increase in fat intake. Supplementation of all the vitamins and trace elements is recommended. Improve the balance of the immune system, improve respiratory function by stimulating antimicrobial peptide production and increase antioxidant properties. Thank you.
Thank you, ma'am, for showcasing and taking us through the overview of nutritional management in a PICU setup for those kids who require enteral feeding. Just also wanted to know if you can also touch based upon the kids who are suffering from pneumonia or maybe other illnesses of respiratory origin, and they are not requiring a critical care, but they are in hospital, maybe they are in a OPD setup. So what maybe suggestions or maybe something which you would like to tell to our fellow pediatricians who are listening to you as to what should they consider in terms of the nutrition, wherever in those cases the dietitian is not available most of the times?
Oh. Yeah, that's good. But most of the time, I think is just good nutrition. And let me share with you that 90% of us Indians don't take adequate proteins. We did a little study, and I'm talking of the good social group. If you ask anybody, or you go to the higher social group or to the lower social group, our protein intake is very, very inadequate. So for anybody, the guideline would be to avoid overnutrition and undernutrition in these patients. Just see where they are in terms of their weight and height and where their scores are, and then aggressively increase their nutrition. And if somebody can just counsel them on how to improve or make their food calorie or protein dense, that's how we tell our patients, because the volume they eat is probably half a katori. So if they can, add maybe a little grated paneer to it, or maybe add a little whey water to it. Or I normally tell my patients, they can make a roti, not a plain chapati, they can make it with dal. So you make a dough with dal. So you smuggle it or cheat in, or you have to be extra smarter than the children, and make sure that they eat better. So the little small volume should be nutrition dense. Make sure that the proteins are through the day, and which, as I said, 90% of us don't eat. It's normally a cereal-based breakfast with upma or poha or maybe a toast. And there's chapati and ghee. I don't know, everybody thinks ghee is a green vegetable and the best vegetable to be eating. And maybe a katori of dal for dinner. So that's the only protein that all of us actually eat. And I also include that into my adult category. And some may afford milk. It would be lovely. There is no harm at all in taking milk or room temperature curds unless he has an allergy to it. So there are a lot of myths around milk and curds and banana. But yes, warm fluids are very, very helpful for these patients, especially in the acute phase when they're coughing a lot and when they are really critically ill. And not to say that my science is saying it, but Ayurveda, you've heard a lot, giving a little pinch of turmeric. There is a lot of science, supported with science, with milk, goes a long way. But a lot of warm fluids, and Dr. Katyan just said in the beginning, getting omega-3 happening maybe from our seeds, from our nuts, if they can afford, and even making sure that we get a little sunshine, or vitamin D supplementation, which probably the medical team will help us with. So supplementation with a normal food diet and hygiene and hand hygiene is very important for these particular patients.
Well, thank you, ma'am, for this. Dr. Karthikeyan, would like to understand from your clinical perspective also in your clinical practice, when you discharge a patient suffering from pneumonia and he is now fine to go back home, do you also recommend some of the nutritional care practices for maybe to the caregivers or to the parents, and for how many days that practice needs to be followed?
If at all, if you are handling a child, it will be a holistic approach. As you said, we start with the basic assessment of their growth and development. So we categorize them whether they are normally nourished, overnourished, or undernourished. And after the point of time when you are admitting and discharging, what is the weight difference that's happening? What is the calorie gap? What is the protein gap? And especially lipids. So generally, we leave alone lipids. Lipids are the major thing in our diet, which helps in recovery. So, and for growth, especially for children, no lipids, brain growth. Without lipids, nothing is going to happen. So we have to categorize all these things. And as a dietitian said, the vitamin D. So vitamin D supplementation along with micronutrient supplementation, and find out the gap in the calories, protein, and lipid, and giving them a diet plan accordingly, and a supplement. Supplement can be in the form of a oral vitamin supplements or oral nutritional therapy is generally being followed up. So that's how we manage them regularly. And it has helped us in a big way, not only the medicine. So even if it is going to be a simple fever, let us alone leave that community-acquired pneumonia or a sick child. Even if the child is coming with fever, the first advice we give is adequate hydration. So there starts the treatment, adequate hydration, then comes the nutrition, then the medication. So that's how we go around.
Great. Not only just the enhancing the recovery of these kids from various forms of acute illnesses, but also to support their catch-up growth, because the kids are growing very fast. Dr. Namit, and I'll come to each one of our keynote speakers just to wrap it up as to what that single message would you like to give to the pediatricians. There are close to 500 pediatricians listening to the webinar, right?
So I think the focus today is on nutrition, and even in the intensive care unit, nutrition is important. It is not just the nutrition aspect. In fact, using the gut has many other advantages. You reduce the translocation of bacteria from the gut. You ensure, even if you give some minimal enteral nutrition, it has huge beneficial effects to it. So there is a definite and a clear-cut impetus on establishing enteral feed. What type of feed, which feed, that could vary from a patient to patient, but nutrition is very important. And as I said, for most of our patients, the target should be to establish some amount of feeds, at least about 30 to 40% of the requirement, daily energy requirement, by about 48 to 72 hours. If we can do that, I think we would be doing a great service to our critically ill children.
Yes, and like Dr. Karthikeyan also showed in the presentation that
Yes.
when nutrition therapy is given along with other modes of management, the overall prognosis and the outcome becomes very improved. Anita ma'am, one last just keynote take-home message for everyone to sum it up.
nutrition is very important, not only for this particular set of patients, for everybody. Not only prevention, also curative, and then on the life. We've just heard that if you don't eat well in the first important 5 years, and that's a critical window, you will have, and Dr. Kent showed it very well, that the economy, these school children will not be actually doing well. Omega-3 has shown, a lot of studies have shown on the brain health of children during pregnancy. Low birth weight for them is hazardous. So you should actually go to pregnancy weights and pregnancy nutrition. So a good diet, holistic, good carbs, healthy carbs, no pure sugars. We are really against sugar, which is addictive, and we are calling it the new cocaine. Adequate protein, plenty of warm fluids to recover, avoid too much of outside food, take care of hygiene, and be safe. Because once you get pneumonia, it can be critical sometimes. In fact, quite a few times.
Thank you so much, ma'am, Dr. Namit and Dr. Karthikeyan, for highlighting that sometimes the most neglected aspect can be one of the most crucial times for kids as well. I would invite my colleague Joytosh to please extend the vote of thanks for all our speakers and the participants as well.
Hello, I am Joytosh Banerjee, and I am the brand manager looking after the pediatric nutrition products of Signutra. So first of all, starting with Dr. A.G. Karthikeyan sir, Dr. Namit Jera, and Anita ma'am.
Sorry.
My heartiest, no issues. My heartiest gratitude to all of you for enhancing the credibility of this advanced webinar series that we have started. This is the second webinar in the series, and sharing your immense knowledge and immense, I would say, comprehensive experience. I mean, I was going through all the slides and a lot of experience, a lot of information I could see, which are very, very practical also. And definitely it will help all our audience members who have been part of this session. Lastly, I would like to highlight some key points like at Signutra, our commitment is always to fulfill the nutritional requirements, providing a customized nutrition to starting from the maternal stage to the pediatric as well as to the adult nutrition. And in this, for this commitment, this is our endeavor, I would say, an initiative which we have started with our advanced webinar series. And I hope that with the presence of eminent speakers, eminent field experts like you, definitely all our pediatricians in the country, they would be benefited with it. And I hope that currently whoever had been part of it, they would have learned a lot of things, and we will keep bringing up such informative webinars for all of them. So thank you very much. Thank you from the deepest core of my heart for being part of this session, ma'am and sirs.
Ma'am and sir, and it has been absolute privilege to host you today. We will continue doing a lot of academic programs in collaboration so that enhancing the entire understanding about the nutrition becomes very, very important. And also this meeting is incomplete without the support, the love and the trust of all the participants which are watching us from the last maybe 90 minutes or so, who have joined from different parts of the country. So a big thank to all the audiences for their continuous support. It actually gives us a lot of confidence and passion to continue this series of advanced webinar. We'll definitely be back soon with some more interesting clinical cases. We'll collaborate again, Namit sir, Karthikeyan sir, and Anita ma'am, to bring such more practical scenarios. Maybe down the line, we are anticipating that dengue, malaria would definitely be on the rise in a couple of months. So we can also shape some of the sessions regarding the nutritional management as a part of the oral treatments of these cases as well. So thank you so much, everyone. Stay tuned, stay safe, and stay healthy. And thank you so much.
Stay healthy is the most important.
Yes.
Thank you.
Thank you.
Thank you
All.
Thank you.
Thanks.
Nice meeting you
Bye-bye.
virtually. Yeah, thank you. Bye-bye.